outlook of having to require these operations. That's one. And the other is that, just like I said before, there are some people, mostly surgeons of course, that believe that medicines may prevent the burning and reflux, but the burning, but it will not prevent the reflux. And maybe it is that some of these changes in the esophagus, in the swallowing tube, and in the stomach could be not because of acid reflux, but because of other things refluxing up there. So if you fix the problem, if you create the valve to prevent the reflux, then that may be helpful in preventing cancers. That's not absolutely for sure. So how do we do this procedure? This is where we put the ports. Those ports are these things. There's 5 of them in this one. That's how I do it. There's the camera port by the belly button and everything else there that I'm not going to try to teach you how to do the procedure. Then you'll put me out of work. That's how the patient's usually laying on the OR table. And there's it's kind of a schematic of the stomach. Okay. That's the liver, but here's the swallowing tube. There's the esophagus. There's the stomach. This is the fundus of the stomach right here. And what we're going to want to do is, this is actually looking through the belly button. This is pretty much the view we get, looking through the belly button towards the stomach, towards the esophagus, towards the hiatus of the diaphragm. This is up here is the chest, and the heart's up here. This is the vagus nerve. It's kind of neat stuff, isn't it? And what we do is we take instruments that we put through these ports, and we're able to manipulate everything. We're able to clamp blood vessels and wrap, isolate little areas around the stomach and esophagus. And what happens is you're taking that part of the stomach and you're pulling it behind the esophagus, and what it does is it wraps around the esophagus. There's the completed procedure. This is called the fundoplication. You saw that it's wrapped around the esophagus. There's a little repair of the diaphragm. A lot of people have hiatal hernias, but everybody that has a hiatal hernia does not have reflux, and vice versa. But very often, most people have this little hiatal hernia, not a giant like your stomach is in your chest. That's a different problem. But this is a little. What this does is this prevents this procedure from migrating up into the chest, which doesn't happen at all that often, but it's one of the downsides of this procedure, open or laparoscopically. But what we do is we make this nice and loose so it doesn't constrict the esophagus, and what this will do is this will prevent the ability of stomach contents from refluxing back up into the esophagus. Now you might say, well, can I burp? Yeah, you'll be able to burp. Most people can. That's a very important thing, by the way. You want to be able to burp. And some people can't throw up too well with this, but it's uncommon for that to happen. So, what are the results? I like this one. 93% of the patients have no symptoms. 4% had only occasional symptoms. We put those on medicine. So that's 97% of satisfied patients. So that's where we like to be. This is Dr. John Hunter at Emory, and he is one of the pioneers in this procedure. And this is a durable procedure, 30, 40 years, and it has great results, and it is relatively, it is the same procedure, and it is safe. So where do we go? The benefits: open, laparoscopic. If I had my operation, this is what I would pick if I needed to have reflux. Now, could you go and have a big plate of spaghetti with marinara sauce, a glass of wine, and a big piece of chocolate cake, and 5 cups of coffee at 10 o'clock at night, and then go to bed? I'm not sure about that. But anyway, it does prevent reflux. Most patients are very satisfied. Some do have to go back on the medicines, but for the most part, it works quite well. There are new procedures. The endoscopic procedure that Dr. Proch has talked about, I'm sure, is in its infancy, just like laparoscopic operations were in their infancy 10 years ago. We're all progressing, and the future right now is open. But right now, the gold standard, in my view, for patients with severe reflux disease is a laparoscopic fundoplication. Thank you.
Dave, you left your toy over here.